Okay, well, let's get started. First, I'd like to thank the Advanced Practice Committee for this opportunity to present a topic that holds a lot of meaning for me, and one in which I think represents a new paradigm in mental health. I'm sure some of you have heard about ketamine clinics, and some of you haven't either, which is okay. Definitely by the end of this presentation, you'll have a better idea of what ketamine is and how it's being used to treat mental health conditions like depression and anxiety. I'll just preface that what I'm about to present will resonate for some of you, and for others, you might feel like it's borderline woo. Either way, you're going to remember this presentation. I'll just start off by sharing a little bit of my background. I've been a certified registered nurse anesthetist the last 8 years, working at UCLA, while also working in the ketamine space. In addition to administering ketamine within the perioperative environment, I do work in a number of different settings where I administer ketamine as an infusion for chronic pain patients at a neurology clinic, as an intramuscular injection at a ketamine-assisted psychotherapy clinic, and just recently started my own practice where I administer ketamine within a somatic ceremonial context. It's been a fascinating journey as I've been able to work with this medicine in a number of different contexts and thus see firsthand how each of these settings impact the client experience. So my intention during the course of this presentation is to provide a brief review on ketamine, along with its underlying neuronal mechanisms and influence on mental health conditions and chronic pain. And I'll also be exploring what healing looks like at the intersectionality of trauma, somatic experiencing, and the non-ordinary state of consciousness that's elicited by ketamine. One thing I forgot to share is that over the last couple of years, I've completed numerous somatic trauma therapy workshops. And later on in the presentation, I'll dive deeper into what somatic therapy actually is. And additionally, I just completed a year-long psychedelic therapy program, and I'm currently enrolled in the MAPS MDMA therapy program, as well as a Psych NP program. And so obviously I'm very passionate about this space and really see this stuff as the future, or rather the present, of mental health. And just to show a small photo of what my therapeutic container looks like when I work with clients. So the whole idea is to encourage individuals to get out of their thinking mind, where they're constantly judging, analyzing, and deciphering their feelings, emotions, behaviors, and stories, and shifting that perspective to an observing mind, where the emphasis is noticing and being curious about physical sensations that arise in their body without judgment, without needing to label them. And this is a big point I'd like to make, and one in which I will explain in greater detail and will continue to repeat over during the course of this presentation. And it's that our autonomic or our physiological state completely influences our behavioral and emotional experience. All right, so let's just jump into a historical primer on this drug. The history of ketamine began in 1926 when scientists first synthesized phencyclidine. It's also known as angel dust. It was originally marketed as an anesthetic in the 50s under the name Ceremonial, which was supposed to be short for serenity, but obviously taking angel dust was anything but serene. High rates of emergence delirium was associated with its use, and it was eventually discontinued as an anesthetic. And then fast forward to 1962, ketamine was synthesized as the third iteration of phencyclidine. By 1970, it was approved by the FDA to use as an anesthetic. And in fact, its use was ubiquitous during the Vietnam War due to its multifaceted properties. It's an analgesic, it's a hypnotic, it's an anxiolytic, and best of all, it preserves and maintains cardiopulmonary function. And then in the 80s, a team at Yale was using ketamine to study the symptoms of schizophrenia, but then noticed it often enhanced people's moods. In the 90s, it was also discovered to be a great adjunct in treating individuals with chronic pain. And then from 2000 to the present, that's when we really started to see great interest in the effects of ketamine to treat mental health conditions. So far, I believe there have been 83 studies performed, 29 RCTs, 21 observational studies, and 33 systematic reviews. So we're going to briefly jump into the neurophysiological mechanisms underlying ketamine's effect on the nervous system. So ketamine is an NMDA antagonist, and it's often used in the chronic pain population. So activation of the NMDA receptor is associated with hyperalgesia, neuropathic pain, and decreased functionality of opioid receptors. And by antagonizing the NMDA receptor, theoretically, ketamine ameliorates the aforementioned symptoms. But over the last decade, there's been a significant amount of attention placed on ketamine's effect on the AMPA receptor, which mediates a number of downstream effects that include increased production of brain-derived neurotrophic factor and mTOR rapamycin, both of which are presumed to play a role in enhancing neuroplasticity, which basically describes the process by which the brain changes, grows, and reorganizes itself to experience. When we think about individuals suffering from mental health conditions, what's happening is that there's this ruminative process occurring whereby an individual is stuck inside their thoughts and their emotional experience. So the underlying assumption with using ketamine is that by inducing neuronal tissue growth, this provides the template for an individual to engage in healthier patterns of behavior and thought. So any discussion about the NMDA receptor warrants a discussion about central sensitization, which describes the process by which the nervous system exhibits a hypersensitive response to normal stimuli. Chronic nerve damage releases pro-inflammatory mediators, which can cause a redistribution of sodium and calcium channels. As a result of this redistribution of ion channels, what you'll see is spontaneous firing and functional changes within the dorsal horn of the spinal cord, as well as changes in several areas of the brain that process pain. And what you end up seeing is a nervous system that is in a persistent state of high reactivity. NMDA receptors are widely expressed within the central nervous system, and a high concentration of them can be found along the dorsal horn of the spinal cord. So when the NMDA receptor is activated by sustained and intense pain stimuli along the dorsal horn of the spinal cord, and is left untreated, long-term changes in pain perception can occur, which is something we often see in the chronic pain population. Interestingly, there are at least 17 known pathways in which ketamine mediates its effects. It's often been touted as a pharmacologist's nightmare, but as previously mentioned, most of the attention has been spent on its effect on the NMDA and AMPA receptors. One idea I'd like to bring up is that when we think about central sensitization, most providers tend to think of chronic pain, but when you consider the definition of central sensitization, a nervous system in a persistent state of hyperreactivity, this can also encompass a wide range of other diagnoses that go beyond chronic pain and can include depression, anxiety, headaches. Because really what we're talking about from a conceptual framework is that irrespective of the diagnosis, the underlying feature is that these are all chronic stress states. And so what happens in a chronic stress state? We start to see, neurophysiological changes such as an imbalance in neural core networks, neuroendocrine and immunological dysregulations, BDNF deficiency. And all of this leads to this global atrophy of synaptic connections within the central nervous system, particularly within the prefrontal cortex and hippocampus. This atrophy of connections can both lead and reinforce many of the symptoms expressed by those suffering from chronic pain and mental health disorders. Symptoms such as excessive rumination, negative thinking patterns, and inadequate emotional regulation are expressed, and they lead to depressed moods, cognitive rigidity, and poor social skills. Now, there have been a number of preclinical trials that have been performed on rats to study how ketamine stimulates neurogenesis. So if you notice on the image to the left, that's titled baseline, you can see a normal dendritic spine from a rat's brain. And in the middle, in the middle image titled chronic stress, what we see is the atrophying of a neuronal dendritic spine that's exposed to stress. And on the image to your right, ketamine has already been administered, while also subjecting the rat to the same stressor, and you can see a greater density of neuronosynaptic connections that are formed. And it's through this pathway that's hypothesized as the mechanism that leads to a relief in depressive symptoms in individuals. So just to summarize the neurophysiological effects ketamine has on the brain, it's an NMDA antagonist, right, that mediates its action along the dorsal horn of the spinal cord and within the brain. This leads to a surge of extracellular glutamate, which activates postsynaptic AMPA receptors. The activation of the AMPA receptors leads to potentiation of several protein kinase pathways that lead to the growth and enhancement of synaptic plasticity. And lastly, I just want to touch on what's happening on a global scale when we're talking about inducing neuroplasticity with ketamine. So the idea behind using ketamine is that leads to an enhancement of global brain connectivity, decrease in tropic brain activity, and increased single neuron excitability. So what does this all actually mean? So there's been a lot of interest in this concept of the default mode network, which is comprised of a number of different areas of the brain, which include the medial prefrontal cortex, the anterior posterior cingulate cortex, the insula, and the inferior lateral parietal cortex. And it's surmised that the experience of the ego emerges from this rather complex neural network of brain regions. And so basically with individuals suffering from chronic pain, mental health disorders, they have a hyperactive default mode network. So a hyperactive default mode network usually presents with cognitive rigidity, excessive rumination, and depressed mood. But the use of ketamine has been demonstrated to decrease default mode network activity and allow an individual to feel more open, to experience greater cognitive flexibility, and develop a greater capacity for emotional regulation. So we're going to be moving into the second part of this presentation, which is looking at how trauma impacts the autonomic nervous system from a polyvagal perspective. And it's from this framework that I base much of my work with ketamine from. We went into the neurophysiological mechanisms of how ketamine works, but clearly there are psychological mechanisms at play when talking about inducing non-ordinary conscious states within a therapeutic relational container. When you think about how healing from emotional wounds occur, I mean, it's not done in isolation. Oftentimes these wounds have a relational component to it. You know, we can think of things like neglect, abuse, negative communication styles, isolation, parental stress, economic stress. I mean, these are all examples of risk factors that lead to a disruption of connecting to an authentic self. And so it makes sense that part of the healing process requires a relational approach. And so when we're talking about trauma, I think most people tend to think of it as an event that happens to an individual, like an assault or car accident, something big, right? Some big experience, rather. And we usually view it within a cognitive framework, which is the constant reliving of like difficult and challenging memories. And that's partially true. But I think in trauma therapy, the emphasis is less on the event itself and more on the consequences of how that event affects the physiology and the nervous system of the affected individual. By broadening our perspective on the impact that trauma has on physiology, it opens up space for us to see how things like neglect, abandonment, misattunement can lead to development of trauma. And I think it's important to note that with trauma, it breaks down our sense of safety, connection, and dignity within our bodies. And when we don't address that disconnection that happens in our mind, body, and spirit, this stuff manifests as anxiety, depression, addiction, PTSD, OCD, and can even contribute to the development of autoimmune disorders. And so, simply put, trauma leads to a dysregulated nervous system. So the solution is targeting our interventions to regulate a dysregulated system. And this is an important conceptual framework to establish because it shifts our thinking and approach of this topic from one in which individuals have total agency over their trauma to an understanding that the reaction to their trauma is the result of an autonomic experience of danger. And, this is akin to having surgery, right? Patients can't think or will themselves to heal. The physical body needs time, patience, and support in order to naturally heal. And I would argue that this is no different with emotional trauma. One thing we need to be mindful of with the healing journey is that it's often a nonlinear experience. And it can feel quite disjointed and disordered. But I think it's particularly important to help clients become more oriented to the process of healing, as opposed to being fixated on the outcome of healing. It's akin to working out. There's no endpoint. You're just engaged in a process that facilitates an overall sense of well-being. And this is also another point I make to clients who seek out treatment for their conditions. Somatic experiencing and ketamine are not meant to be curative, but the goal is to help move you in a direction where you're engaging in behaviors and actions that feel more authentic to how you want to live, as opposed to feeling as though your symptoms are dictating your lived experience. And so we need to remember that we have a body, a nervous system that's actually laying the template for how we're perceiving and thinking about our reality. And, we think our minds are in control, but I argue it's our body, the autonomic nervous system, that's in the driver's seat. And one fun fact that I like to share, and it's something that plays a role in how trauma is processed, is the vagus nerve, which is the primary conduit of the autonomic nervous system. 80% of the vagus nerve fibers are sensory or afferent. So that means 80% of the activity expressed by the vagus nerve is the body sending signals to the brain, while the remaining 20% is motor or efferent, where the brain is sending signals to the body. And so just let that land for a moment. 80% of our lived experience is happening on a subconscious level. On a second-to-second basis, the nervous system processes 11 million bits of information, but our conscious minds can only handle 40 to 50 bits. So just food for thought in terms of who's really in the driver's seat. I'm going to continue this discussion on the intersectionality of trauma, somatic work, and ketamine with a basic primer on polyvagal theory, which looks at the autonomic nervous system as the foundation of our lived experience. We've been trained to view the body's autonomic reaction to stress in a binary fashion. Either you're in sympathetic fight or flight, or parasympathetic rest and digest. Polyvagal theory takes a slightly more nuanced view with the parasympathetic division in order to take into account some of the symptoms experienced by individuals suffering from the chronic effects of trauma. When you read the accounts of people suffering from severe trauma, you often hear things like, I froze, I dissociated, I disconnected. And the question ends up being, how does this fit into the binary understanding of the autonomic nervous system? Because when you're in danger, you're going to be sympathetically activated and you're going to be going into fight or flight. So where does disconnection and dissociation fit in? So polyvagal theory is characterized by three organizing principles: neuroception, autonomic hierarchy, and co-regulation. Now, neuroception is how our neural circuits decide in the moment if a person or situation is safe, dangerous, or a major threat. Neuroception listens to three streams of information, right? Inside the body, outside the body, and between the body, or rather, within social situations. Now, recall that 80% of the vagus nerve's function is sensory. So you can think of neuroception as the nervous system's surveillance system. So based on the signals it's picking up, it will ultimately lead the body to transmit to the brain that it's either safe or in danger. And from this foundation of neuroception is where our cognitive story about our lives stem from. That inner dialogue of I'm a loser, I'm wonderful, I'm smart, I'm insecure, all of this stems from an autonomic experience. And the sequential diagram below shows how we move from neuroception to perception to state to feelings to behavior and then to story. We often fixate on our feelings, behaviors, and stories when we're looking to change our lives, but if our autonomic nervous system continues to detect danger in its surroundings, then it makes it particularly challenging to produce sustained, meaningful change. um, Autonomic hierarchy, as defined by the polyvagal theory, describes the different physiological states that the vagus nerve can lead us to, depending on whether we're experiencing a neuroception of safety versus danger. The vagus nerve is cranial nerve 10 and bifurcates at the brainstem to a ventral and dorsal branch. The ventral vagus nerve innervates most of the organs above the level of the diaphragm, which includes the heart, the lungs, along with many of the other skeletal muscles on our face, while the dorsal vagus nerve innervates the organs below the diaphragm. Each branch plays a role in determining how we respond to cues of threat, to cues of safety in our environment. The ventral vagus nerve is known as the social engagement nerve and is a parasympathetic state. So when we feel connected to ourselves, to others, when we're experiencing a neuroception of safety, our ventral vagus nerve activates physiological responses that convey safety from one nervous system to another. So what happens when we move from a neuroception of safety to a neuroception of danger? Well, our nervous system responds in a hierarchical manner. So we move from parasympathetic ventral vagal activation to sympathetic mobilization or fight or flight, where we act in a defensive manner and become engaged in action to remove ourselves from a real or perceived threat. And this is where polyvagal theory's contributions are significant. So what happens to a person when they're pushed beyond their capacity to be in fight or flight? Well, they go back to parasympathetic activation via the dorsal vagus nerve. So dorsal vagal activation leads to behavioral responses such as immobilization, feelings of terror, collapse, freeze, hopelessness. A great example of this are those war movies where you see that soldier, right, who goes into battle in sympathetic fight or flight, but then all of a sudden freezes and is overcome with fear and is unable to move forward in battle. Given that the dorsal vagus nerve innervates the organs below the level of the diaphragm, what kind of physiological symptoms would you expect to see? GI distress, bloating, diarrhea. These are all global symptoms experienced and reported by individuals suffering from severe and chronic trauma. And so our biological imperative is seeking safety through social connection. And part of establishing social connection is through co-regulation, which is the sending and receiving of safety signals from one nervous system to another. This is done through an activation of the social engagement nerve, which, if you recall, is the ventral vagus nerve. And the best example of co-regulation is that of the parent-child dyadic relationship, where the parent recognizes the child's changing autonomic needs and responds appropriately. And in this co-regulation of autonomic states, there's a shared autonomic experience, a shared emotional experience, and really at the heart of it all, a shared sense of safety. And that's the foundation of co-regulation. Now, this is a great conceptual diagram that visualizes how our nervous system on a moment-to-moment basis fluctuates back and forth between sympathetic and parasympathetic activation in order to maintain emotional homeostasis. It's known as the window of tolerance. When a person is operating within the optimal arousal zone, it means that they're effectively managing and coping with their emotions. But for clients who experience trauma, they have difficulty regulating their emotions as their window of tolerance becomes quite narrow. So when someone is traumatized, it can be challenging for them to be present with their emotions, as these individuals are often stuck in the past trying to cope with their trauma. Anyone who's ever taken care of a severely traumatized individual, you definitely see them in the ketamine space. That's exactly what I'm referring to. The stress of a traumatic memory or trigger can often push an individual out of their window of tolerance. Even minor stressors can cause a client to dissociate, get angry, or feel anxious. And so one of the questions is, how do you help people with a narrow window of tolerance expand their emotional regulatory capacity without becoming dysregulated? So, I know you've been hearing this term somatic work experiencing, and probably wondering what the hell is this guy talking about? We've reviewed the neurophysiological mechanisms of ketamine, looked at how the autonomic nervous system is shaped by trauma through a polyvagal perspective. And in this section, we'll explore somatic experiencing, and then I'll tie it all together. So, in short, somatic experiencing is a body oriented therapeutic model to healing trauma. Because essentially, what you're trying to do is work in a slow, stepwise manner where you're assisting an individual to relearn and reorient their relationship to their own body. As I shared earlier, we often fixate on our feelings, emotions, and stories about our lived experiences. But according to polyvagal theory, we need to target our interventions at reorienting autonomic state in order to expand that window of tolerance so that one is able to change their feelings, behaviors, and stories. Part of targeting autonomic state involves focusing on the sensations one experiences on a moment-to-moment level. Again, shifting from the thinking mind where we're constantly judging, labeling, and analyzing phenomena to an observing mind where one just notices, takes an inventory, and approaches phenomena from a place of curiosity. And what happens when you're curious? You're much more open to understanding what's happening around you. And when you're approaching your body with that same sort of curiosity, then the sensations that arise from your moment to moment experience become less scary. And theoretically, you're better equipped with being able to be in the present moment. And so somatic experiencing is really a holistic modality that recognizes that there is a mind-body connection to healing. Now, if we continue to experience a neuroception of danger and don't address the root cause, it makes changing our feelings, behavior, stories much more challenging. Again, we're just inviting clients to move away from thinking and discerning to just noticing, and noticing bodily sensations from a place of curiosity. And inviting this approach really opens up a lot of doors in terms of figuring out how you want to move forward with what's coming up inside. And, this is where the multidisciplinary approach becomes imperative, where the involvement of a therapist, psychiatrist, or mental health professional can play an integral role in helping a client better understand what's happening at the level of their feelings, behavior, and story. And so we're going to spend the next few moments I'm going to spend the next few moments to demonstrate what a somatic experience feels like, because it's more of a felt sense experiential exercise than it is a cognitive exercise. I can't stress enough the idea of moving away from a thinking mind perspective and leaning into an observing mind perspective. We'll start. So, when I say the word psychedelic, let's just notice what comes up for you and just sit with that. Psychedelic. And notice how it impacts your mind, your body. What kind of images come up? What kind of feelings, beliefs, thoughts, sensations. Could it be this? Or perhaps this? And for this photo, I just want to clarify that this is meth, not a psychedelic. But I put this up because for some people, what can come up when the word psychedelic is mentioned is something that's illicit, illegal, and taboo. But just notice how it shows up in your body. And for some people, the term psychedelic can also elicit this: ceremony, sacredness, reverence. And lastly, it could conjure up this image. And just notice what's happening inside of you from a felt sense perspective. You know, when you saw those images, some resonated, some didn't. But it's that quality of being that's the basis of somatic experiencing. And that's the crux of these somatic sessions that I lead with my clients, helping someone to just notice. So the idea behind somatic experiencing in ketamine is to focus on expanding an individual's window of tolerance in order to help them manage difficult and challenging emotional, physical experiences, so that they can be more present with themselves and not be so fixated on their past or their future. And just bringing this full circle and connecting the dots between expanding the window of tolerance, somatic experiencing, and ketamine. So the whole goal of this process is to expand their window of tolerance through an activation of a number of neurophysiological and psychological processes. So the administration of ketamine induces neuroplasticity, which enhances mood, while somatic experiencing helps an individual to notice and observe their sensations. And from there, through the process of integration, which I'll explain more in greater detail later on in this presentation. But integration is when an individual starts to develop a new understanding of their self, where they've learned to redefine their relationship to their emotions, feelings, and stories. So what exactly am I basing my interventions off of? Because I know it's probably starting to feel like I'm veering into this new age space. Turns out that the National Institute of Mental Health determined that a single dose of 0.5 milligrams per kilogram of ketamine has been demonstrated to treat a whole host of psychiatric disorders. Most of the evidence related to the efficacy of ketamine is centered around its treatment, is centered around individuals suffering from treatment-resistant depression, which is the failure to respond to 2 or more antidepressants. The most recent evidence seems to suggest that there's about a 60 to 70% response rate in the reduction of depressive symptoms after receiving ketamine versus a 40 to 50% response rate with SSRIs. The current evidence recommends the administration of approximately 6 treatments within a 2 to 3 week period. But I'll be honest, this treatment protocol is very much open for debate. Because what that evidence is saying is you're administering ketamine without any sort of psychosocial support, right? So when you're administering ketamine absent that psychosocial support, the literature reports that most people experience a benefit that lasts anywhere between 2 to 4 weeks. So the question is, so we know ketamine can ameliorate a lot of deleterious symptoms related to mental health, but how do we sustain those benefits so that they provide lasting relief rather than creating a situation where someone needs to show up at a ketamine clinic or get, ketamine mailed to their home every 4 weeks? So my model of care is based off of a ketamine-assisted psychotherapy model, which moving forward in this presentation, I will be referring to its shorthand as CAP. Now, to be clear, I'm not providing psychotherapy, nor do I make claims that I am providing psychotherapy, at least not until I become a Psych NP. In a CAP model, there are 3 phases to the client experience: preparation, the medicine journey, and integration. I can't emphasize this enough, but preparation is paramount if one is to maximize the degree of benefit from this treatment. But as I say this, I'm realizing that approaching this work is very much like approaching meditation. You're not really trying to achieve anything. You're just learning how to be in equanimity with whatever is unfolding inside of you. But I digress. As you can see from this slide, there are a number of factors that can and will influence the outcome of the experience. In the CAP model, there's a huge emphasis on this idea of set and setting, which is short for mindset. And it's centered around the expectations a client has towards their experience. What are their psychological, emotional, spiritual, and somatic expectations prior to jumping into a non-ordinary conscious state? Now, this is usually established over 1 or 2 sessions with a client. And so mindset is about intention setting and reviewing the therapeutic goals that one seeks with their treatment. Part of the preparation I go through with clients is through doing somatic work. And the other part involves educating them about ketamine, the protocol that's being used, and reviewing strategies on navigating, different state of being, which I'll give you a hint. It's learning how to surrender to the moment. So setting is basically all of the variables outside of the client's internal process. So things like the therapeutic relationship between provider and client, the environment with which the sessions are being conducted, the music that's being used or played, the experiential quality of the therapeutic container that's been created. My job as the provider is to create the conditions necessary to allow a client to feel safe, regulated, and supported to explore the 10,999,950 bits of information that their nervous system is processing. And that's a huge reason why I opt towards a ceremonial approach with ketamine, because everyone knows what ceremony conveys: a sort of reverence and sacredness to the experience. And it helps clients from viewing challenging moments as negative or bad and to see them as growth opportunities, because there's something to be learned from this experience. Then you have the journey, which in my practice I administer as a subcutaneous or intramuscular injection. The experience lasts anywhere between 45 to 60 minutes. And my job at that time is to hold space and witness what's unfolding for the client. And finally, there's integration. Typically, it occurs a day or 2 after the medicine journey. Basically, it's providing space for a client to review their experience and find meaning behind what they saw. I think with this delivery model, it moves the client from a passive role where they show up to receive medication to one in which they're being proactive with their healing process. So putting it all together, we're back to how I personally perform ketamine sessions. But I'll start off with this question, right? At least for like prospective clients. What would it mean for you to be witnessed? What would it mean for an individual who spent a significant part of their life feeling unheard, unwitnessed, invalidated? What if there was a therapeutic space available for an individual to enter so that they could express, sense, and feel the things that they were, told not to express? And by inviting an individual to fully feel and explore whatever emotions, memories, images, or body sensations arise, can potentially lead to the resolution of deep-seated patterns of fear, powerlessness, guilt, and shame. So typically my sessions are usually around 2.5, 3 hours. I take about 45, 60 minutes to establish the therapeutic container, where I check in with the client, see where they're at, and review their therapeutic goals. And during this time, I'm doing a mix of somatic work, guided meditation, breath work, and sound healing, where the goal is to facilitate this transition from being, cognitively focused to a state that's more focused on the body. As I said before, moving out of the thinking mind and into the observing mind. And once a client taps into their nervous system and begins to notice their sensations and perceptions, they're basically developing an internal roadmap of what's arising in their body. And it's been my experience that when you get someone into a space where they're connecting with their bodily sensations, it makes the medicine session with ketamine much less formidable and intimidating for the client, because all that's happening is that they're being reconnected to themselves. So due to time constraints, I won't be able to spend much time on this slide, but if your question is, do ceremonies work? Well, the literature does in fact support the idea. They do, right? And for me, a major reason why I've incorporated a ceremony into my sessions is that rituals have a causal impact on people's thoughts, feelings, and behaviors. What ceremonies and rituals do are that they enhance people's confidence in their abilities and can potentially lead to a deepening of one's experience and heightened emotional stability. Attributes I'd argue you would want to show up in this kind of space. So we've made it to the end of the presentation, but before we end, I found this table in a transpersonal psychology journal and thought it'd be interesting to share how psychiatry and psychology administers ketamine, or at least labels what the dose, what kind of experience the dose can elicit. So we have at the lower end an empathogenic experience, also known as the heart opener. Mid-tier dosing, people report experiencing an out-of-body experience. At the next tier level, people report experiencing a near-death experience. And then at the highest, which I believe is 2 milligrams per kilogram, people then report an ego-dissolving transcendental experience. And what's fascinating to me is that when you get to that stage, what is depression, anxiety, addiction, and pain if there's no ego to experience it? It doesn't even exist. This quote, I think, just perfectly captures the ethos of what can happen when you're on a healing journey that interfaces with a non-ordinary state of consciousness. So yeah, the clearer we are, the more resonant we become, and the more we synchronize with what is. In this enlightened state, both happiness and joy come easily because we are present and in the moment within. This is my website for those who are interested to learn more about this process. I'm actually collaborating with some providers to develop a multi-day group experiential retreat for healthcare, mental health providers who have been burned out and affected by COVID. Though really, we've all been burned out well before COVID. Again, I'd like to thank the committee for the opportunity to share what I've been doing these last few years, and thank you to everyone who arrived today to watch this presentation. Thank you.